morning, everyone. My name is Maya Luria with TMC for Seniors, and today we are continuing on with our Diabetes Month, and we're going to be talking about diabetic foot care, prevention and treatment. I've got Natalie Norem here with me. She is a board-certified family nurse practitioner, and she's actually got two hats. She is with our TMC Wyatt location, and she is also part of our TMC Wound Care. Welcome, Natalie. How are you?
I'm good. Thank you for having me. I'm really excited to be here.
Yeah, so I know that foot care is such an important topic, particularly if not for everyone, but particularly when you might have diabetes as well. And so you're going to be sharing all about that this morning, and I think it's great for people to know. We'll learn a little bit more about wound care in general, which will be good, so that we can at least share that information. So I'm going to go ahead and put your PowerPoint up for you so that you can go ahead and get started.
Great. Thank you again. It's really nice to be here. I really enjoy giving these talks out in the community, and I think we're going to have a good time today. I have a lot of information, and we're going to have time for questions at the end for our in-person and our live streaming audience, okay? So let's get started. So just to let you know, I don't have any kind of financial funding or anything for talking today. I'm not paid by any other organization. I'm employed by the hospital here. And you'll see on the lower part of my slides, it says Helogix. That's our national wound care organization that we partner with here at TMC. Just a little bit about me. As Maya already said, I'm a nurse practitioner. I got my bachelor's in nursing in 2003 from University of Illinois, and then my master's from University of Illinois Chicago in 2009. I have some nursing background in ER and pediatric, and then I've been a nurse practitioner for 15 years, and that's in primary care, wound care, and urgent care. And any reason for me to brag about my kids? Those are my two kids, and my poodle was trying to get in the picture there. Oh, what happened to this slide? It's missing all the numbers. Here it comes. Okay, so let's talk about diabetic statistics. So as you probably well know, diabetes is a huge health problem in our country. And you can see here that 28.7 million people have been diagnosed. In the 65 and older group, that's 26.4 million people. And looking at the statistics, 48% of 65 and older have prediabetes. So that's when your fasting blood sugar is in that 100 to 120 range. So that's quite a bit. You've got 8.5 million people undiagnosed. I just had 2 patients yesterday that were new diagnoses and have had it for a while and didn't know it. And 37.3 million total. So that's 11.3% of our total population here in our country have diabetes. And then when you look at the prediabetes, it's an even bigger problem. 38% of our population in our country has prediabetes. So this is a very prevalent issue. It's really a disease of our modern lifestyle. So just a little background on diabetes. Why do we even get this? What is this? Why does this happen? Well, we're probably all aware that obesity and being overweight leads to diabetes. That's one of the big factors. What happens is that causes sort of this inflammatory cascade in our body, gets us into insulin resistance. And we're talking specifically for today's talk mostly about type 2, and that's what I'm talking about right now. There's different types. Our pancreas overproduces insulin, our body doesn't use it effectively, our blood sugars go up, and we get complications. And you can see on this slide, there's some other things that can cause it. And of course, we know genetics. Certain families, certain ethnicities have higher rates of diabetes. Certain kinds of medicine, and then lifestyle. That sedentary lifestyle, the processed junk foods, all those things increase your risk. And age, unfortunately. That age, is the older you get, the more common it is. And diabetes is really a disease of every part of the body. We can't just look at one thing like the foot and not think about what is it doing in our other part of the body. And so this slide talks about all the different things that it affects. It increases your risk for stroke and heart attack. Those peripheral arteries in your legs, it can destroy those and cause problems in your circulation. The eyes and the retina have very delicate little tiny blood vessels, and the diabetes can wreak havoc in there as far as causing inflammation, decreased eyesight, and in worst case scenarios, blindness. We're going to talk specifically today about diabetic foot, and then kidneys. You may know somebody who's got decreased kidney function or gone on dialysis when their diabetes wasn't well controlled. Those little nephrils, or the little filtrating units in the kidneys, they don't like high blood sugars, and it can damage them. And then the nerves in the legs. Diabetes, you may have heard of diabetic patients say, oh gosh, my neuropathy is bothering me today. It's burning. So that can also cause problems. And we're going to talk about neuropathy a lot today with our talk. The other thing I wanted to say as I go through my slides, in wound care world, we kind of talk about wounds as ulcers. So when I say wound or I say ulcer, I mean the same thing. So why are these funny looking body parts so important? Maybe you haven't had a foot problem, so you don't really know that they're that important until your foot starts hurting and you can't walk. So in your lifetime, you're going to walk approximately 100,000 miles, which is pretty amazing if you think about it, how much work is going into those body parts. About 60 to 70% of people with diabetes develop neuropathy, which is really the biggest cause of diabetic foot ulcers. And then chronic foot pain, if any of you have ever had foot pain, it's pretty miserable. It has a huge impact on your quality of life. You can have loss of mobility, and of course that leads people to be depressed when they can't do their activities they enjoy, if they can't work. You can get increase in your weight, leading to more heart disease, stroke, osteoporosis, and if you're still working, income loss. So here's one of my gross pictures. Us in the wound care world, we like wounds, and we enjoy these gross pictures that we look at. So I hope you guys are okay with them. So this is a classic diabetic foot ulcer, plantar, so the bottom of the foot, diabetic foot ulcer. We see these kinds of ulcers over in wound care quite a bit. I at least have one in my schedule every day, to be honest about it. And they can take a really long time to heal. Being on the bottom of the foot and us walking can cause a lot of problems. So let's kind of dig into this and why does this happen? Why do these diabetic foot ulcers occur? Well, there's three main causes. The first is that peripheral neuropathy. Our nervous system has many functions, and these are kind of the three major functions: sensory, autonomic, and motor. And then, of course, infections. Our skin is one of the biggest preventative things in our immune system to preventing infection, preventing bacteria, viruses, things getting into our body. So when you have a breakdown in your skin and you have a wound, what happens? Bacteria starts to invade in there and you get an infection. And then circulation problems. So you can get problems in the veins and the arteries of the legs and the feet, and that can cause problems. So let's start with neuropathy, because this is really the biggest issue. Like we saw in our previous slide, 50 to 60% of diabetics get this neuropathy. So sensory. We all know that our nervous system is why we feel pain, we feel cold, we feel hot. And what happens is high blood sugars and uncontrolled diabetes leads to inflammation in the lining of those nerves as they travel down in the feet. And you can get decreased sensation in your feet. So what happens when you walk out in your garden, on maybe your patio and you're around your pool? You're going to step on something and you're not going to know that it caused a cut because you can't feel it. Or I have a patient right now I'm treating. He's diabetic. He was walking around his pool. The pavement was really, really hot. He didn't even know, and he got a bad burn on his foot. So that's why it's so important to do these foot care and foot checks, which we're going to talk about a little bit in some future slides. Autonomic neuropathy. So autonomic nervous function is the important things that we do in our body systems every day. Our pulse, our breathing, our digestion, that's all controlled by our nervous system, even though we're not thinking about it. That autonomic nervous system can get damaged by diabetes, and it can cause lots of problems with our skin. Things like hyperhidrosis, which is a fancy word for sweating. So if your feet are sweating all the time, what's going to happen? You're going to get skin breakdown and you're going to get fungal infection. Or the opposite, you can get really dry skin from that autonomic neuropathy, and that's what this picture is showing. And then lastly, motor. So we all know that we need our nervous system to move our muscles in our body and our coordination and all those things. Well, specific to our feet and what can happen is we lose motor innervation or impulses into the lower muscles and ligaments and tendons down there in the feet. And when you lose that muscle tone, your bones start to move in an abnormal way, and you can get what we call Charcot foot, which is when the foot kind of collapses. And you can see this person has a lot of orthopedic abnormalities related to that loss of motor nerves. And when your feet look like this and you try to just wear regular shoes, what happens? They start rubbing. And then when you rub, you get a wound. And so that's how those lead to wound problems. And then infections. I'm sure everyone's aware of fungal infections being more common in the feet. This is sort of we keep them covered a lot. So a dark, moist environment. There's spores from fungus in our environment all the time. They're on our skin. And if you set up the right environment, they like to set up shop and they sit in there and they cause infection. And so those kinds of infections can break down the skin as well. And that lower picture, you'll see that there's a picture of a skin infection or a cellulitis. So the bacteria has crawled into that soft tissue. And if that breaks down, isn't treated, it can cause wounds, and in severe cases get into the bone. And that's what osteomyelitis is. Osteomyelitis is the reason people who are diabetic end up with foot amputations. It's very hard to treat osteomyelitis with oral or even IV antibiotics to try to get it absorbed in your bloodstream, penetrated into the bone. There's a lot of inflammation that's going on. And so this is where we see diabetics end up losing their toe, their foot, even extreme cases, the lower leg, because we don't want that osteomyelitis to spread any further. And then let's talk about the vascular complications. So circulation to our feet, to and from our feet, is sort of the hardest part for the heart to get to because it's the farthest away. Especially with our veins. We have these little veins that have pumps in them, and they bring blood back up from our feet against gravity back up to our heart. And as we age, it happens in everyone, those little veins kind of wear out. They don't work as well as they used to. And so you can get problems with the blood flow coming back up to the heart, and you get what we call venous reflux. And that means fluid kind of sits in your lower leg. And when fluid sits in your lower leg, your skin doesn't like that because it builds up pressure under your skin. And you can see in this picture, this patient has that. He has that darkening or hyperpigmentation of the skin, and he's got that sort of dry, excoriated skin. That's from constant pressure from the venous system not having a good return. When that happens, it can be so severe that it breaks the skin down and you get an ulcer on the foot or on the lower leg. Those dark areas are called hemoceridian deposits. There are other factors as far as your arteries, which are the blood flow to your legs, that can get damaged. These advanced glycogen end products are little proteins that can damage the arteries, and those go up in diabetes. You can have increased oxidative stress. Oxidative stress essentially is part of our metabolic system. We have byproducts of waste. They don't get cleared out well enough, and it can cause problems in the arteries. Endothelial cells are any kind of cells in our body that are on a lining of something, and those line the inside of our arteries, and those get damaged from diabetes. It causes plaques to form in those. Sure, you're all aware of plaques that form in people's coronary arteries. That's exactly what's happening in the legs, same kind of plaques. It's an inflammatory state on the side of that artery wall, and if things get progress enough in the disease state, that plaque can move and clot off the blood flow to the lower leg. And of course, high cholesterol is going to make that happen more often. So we want to talk about high cholesterol in controlling diabetic foot ulcers. We want to talk about lifestyle factors. The more active you are, the better your circulation is. So the more sedentary, the worse off you're going to be. Genetics, of course, we can't change our genes, and we see that certain patients are more prone to these things because of their genetics. And then we've been talking about the big veins and the big arteries, but we also get changes in the very tiny little arteries, and we talked about the eyes, but it happens in the toes. So in wound care and in vascular care, we do toe pressures. So it's a special kind of blood pressure that goes just around the toe. It's a cute little blood pressure cuff, and it measures the pressure that's going on in the toe. And if that's abnormal, we know that that toe has tiny damage in the little vascular space, and sometimes it's hard to get a wound to heal when that's abnormal. Another fun picture of a diabetic foot ulcer, and that's a pretty deep one there. So what can you do as a patient? There are so many things, and we're going to kind of talk about that throughout the talk. But of course, number one, blood sugar control. If your blood sugar is higher and your A1C ideally should be below 6.5%. Does everybody know what an A1C is?
Yes.
Okay. And for those that don't, it is an average of your blood sugar over the last 3 months. So it's a much better test than that one test we get that day of your fasting blood sugar. That gives us information, but we love this test because it can tell us what you've been doing over the last 3 months. So if you're cheating, we can find out. That test is really what all your providers want to look at and control, and that should be less than 6.5%. Ideally, there are certain cases where maybe 7.5, depending on other factors going on. If you're very, in the older age, over 85, 90, we don't get so crazy about controlling it as tightly, but typically 6.57. And then if you notice you have poor circulation, you have cold feet, maybe you're having pain when you're walking, those are things to talk to your nurse practitioner or your doctor about. If you notice you have those orthopedic foot deformities, you got to let us know so we can get you into podiatry and get some special shoes made. Dry, discolored skin, cracks and fissures, anything on the skin that's not normal might break down and become a wound. We want to get on top of right away. Changes to the toenails, because around the toenail edges, we can see wounds start to develop. And of course, if you see a wound, you get in and get care right away. So this slide, I'm going to talk about our wound treatment. There are so many things we do over at the Wound Care Center, and I want to first talk about the multi-specialty care that really is required for diabetics and their potential wounds. First off, you've got your primary care doctor or nurse practitioner, and they're the ones who should be screening you for diabetes, starting you on medications, educating you on proper foot care. If they see something, then they refer you to the specialist. So you have your vascular surgeons, and they're going to take care of all those vein problems, those circulation problems. And then you've got your podiatrist. Podiatrists can do toenail trimming. They can do callus trimming before it becomes an ulcer. They can get those shoes and the offloading, the special kinds of foam, so you might not be rubbing a certain area of your foot. And then there's us in the Wound Care Center. And in the Wound Care Center here at TMC, we're staffed with surgeons and nurse practitioners like myself. And we have a whole team of nurses that do all kinds of things. And the nurses are a big part of wound care. The first thing is they get you checked in and get your history and all of those things. Then they have a case manager, because I'm sure you're not surprised by this. A big part of wound care is getting things paid for by insurance. And if we didn't have our RN case managers to submit all those claims, get the right evidence and paperwork over to insurance companies, we wouldn't be able to get the things we need for our patients. So that's another big function. And then we have a whole team of nurses that just do dressings all day, because that's its own specialized nursing care. So the reason I'm telling you all that is if you've got a foot wound that really hasn't healed after a week or two and you're diabetic, go to a wound care center. And in Tucson, of course, I'm going to be biased and say we have the best one here at TMC, but I truly do believe that. We also have there's also a wound care center at St. Mary's, and those are the only two outpatient wound care centers. There are some other providers that do wound care. There's some home health wound care, but as far as wound care centers, outpatient, those are the two in Tucson. Because they have all these different treatment options, all these different specialties of people and staff that really know how to get you healed. One of the things I see working over there is sometimes other physicians, surgeons, or dermatologists, even PCPs try to do wound care in their office, which is fine. A lot of times it works. But then if it's not healing, ask for a referral, because that's really what you need. You need the wound care center, okay? Especially when you have diabetes. Don't mess around. Just get in there and get it taken care of before it gets bad. So when you get to wound care center, what do we do? Well, the first thing we do that all of our patients just love, and I'm being sarcastic when I say that, is we take a scalpel or a little curette and we numb you with lidocaine and we scrape off the top of that wound. And why do we do that? Well, wounds, again, as we were talking about before, they love to have bacteria in them, and bacteria is not good for healing. So when we go in there and scrape off all that, we call it slough, which is yellow stuff, or scab, just like a black, dark scab. We scrape that off, we get that bacteria off, that bioburden, so the wound can start healing. When you have all that extra tissue and bacteria on there, the wound's not going to heal. So that's the thing you do once a week in the wound care, and that's really what your nurse practitioner and your surgeon are experts at, is cleaning that wound up with the surgical tool. Then we have all these dressings. The basic dressings that we use for wound care are collagen-based dressings. There's a couple different products that are pretty common. Prisma, Hydrofera Blue, and then we've got Pomegranate. those are impregnated with ingredients that promote collagen and tissue growth. And those get put right on the wound. And they tell that wound, come on, let's get that healthy pink epithelialization going. They also have antibacterial impregnation in them, and silver is one of the ingredients. And that silver really helps it from getting infected. If that's not working, we can put you in a cast, a walking cast. And why would we put a diabetic foot ulcer in a cast? Well, when you have walking on an ulcer and it won't heal because of all the pressure, that cast takes the pressure off. It spreads the pressure around the foot. So that's another option. And you get it once a week. We take it off, check your wound, we put a new one on. We also have really cool products in wound care that are biologically active. They're made from things like placenta cells, sheep cells, pig fetuses, and they actually have real live biological cells on the product. And they go in and go right on top of that wound, and they tell that wound to heal because they're adding in new biological matter. Those products get a little bit more expensive, but when a wound isn't healing, typically we can get insurance to pay for that. Then we have, if you see on that lower picture there, that's one of our hyperbaric chambers. Does anybody scuba dive in this? Does anybody ever scuba dive in this room? Okay. So this is essentially what happens when you go underwater and scuba dive, is what we're doing in our wound care center. And why do we do that? That sounds kind of weird, right? Well, when you go down under water or into higher pressure, you force more oxygen into your tissue. And so this makes wounds that are the more difficult wounds heal faster because they're getting a higher oxygen level. You get medically cleared, you're monitored during the whole session. You go down slowly, you come up slowly, and the whole process takes about 2 or 3 hours. We also, just as a side note, we see a lot of cancer patients in our wound care center that don't have wounds but have radiation burns and tissue injury from radiation treatment. It really is useful for that too. So just interesting, I think, all these things in medicines we use. So you can see it's a very multi-modality kind of specialty. So this is a diabetic ulcer that one of our providers healed. And you can see on the left, it almost looks like this patient might lose their toe. That's how bad it is. And that when I was talking about when we do debridement and scraping, we're getting all that black kind of eschar stuff off. What we want in a wound bed is to have pink healthy tissue. So you can see at the start of it, and then that middle picture, it's looking a little bit better. And then at the end, yes, it's got some scarring, but it's healed and it's looking much better. And this is why we do what we do in wound care. We love this kind of stuff. And this is what happens if you don't take care of it, or you get a bone infection, that kind of stuff. So you can see this patient's already lost their left lower limb, and they're probably going to lose that right toe, if not more of their foot. And unfortunately, once we see a patient lose a foot or a toe, they have a 55% chance of losing another. So let's talk a little bit about wound care. It is a big, big problem in society, and I don't think as a culture we talk about wounds like we do other disease states, maybe like cancer. I think there's a little stigma on it. People don't like to say I have a wound. It's embarrassing. They can be gross and unsightly, but they are really important to know about. 1 in 4 people over 65 has diabetes. 1 in 5 over 60 have that peripheral artery disease that we're talking about, when those arteries get blockages and calcifications and don't have good blood flow in your legs. And when we talk about peripheral artery disease, we're talking about the legs, the arms, but mostly the legs. 1 in 7 Medicare beneficiaries are diagnosed with a wound or wound infection. So you can see how much of a cost it is for all of us in our healthcare system. Patients with untreated wounds are 20 times more likely to end up in the ER. I see this frequently in my patients. They get exacerbation and infection and that kind of thing and end up in our ER. And we all know our ERs are overrun with patients. In busy places, 85% of diabetes-related amputations are preceded by a foot ulcer. So that means if you're not getting in and getting that foot ulcer taken care of, you have a big high chance of having some kind of a complication such as an amputation down the road. And then what I was just saying in our previous slide, 55% require an amputation on the second leg within 2 to 3 years. I think that's just, when you get to that point, your disease has progressed so much, it's hard to pull the train back into the station. So that's why prevention is key. And you can see at the top there, $50 billion impact on our healthcare system. This slide has a lot of information, but this kind of goes back to what I was talking about at the beginning about how significant wounds are in our healthcare system and how there actually has a higher mortality and morbidity than cancer. And this is just comparing to breast cancer. So a 5-year mortality rate with breast cancer. So 9% of people who have a breast cancer diagnosis in 5 years are going to pass away, unfortunately. Well, let's look at our wound care stats. If you've got that Charcot arthropathy, which is that abnormal foot deformity, and you're diabetic, you have a 29% chance. If you have a diabetic foot ulcer, you have a 31% chance. And then all cancers, 31%. So see how close that is to all cancer. Then when we get into the more high-risk wounds and complications, we've got a 46% chance of 5-year mortality with minor amputations, a 53% with chronic limb-threatening ischemia. So that's when you have that loss of blood flow into the leg because your artery is damaged. And then with major amputation, what we call a BKA, below the knee amputation, or a AKA, above the knee amputation, you get a 57% chance of not living longer than 5 years. And then you can see lung cancer is a little bit higher. So what this slide is telling me is that wounds and wound-related complications really decrease patients' time in their life, but they also decrease their quality of life. And that's really something that we try to focus on, especially in the primary care world. So let's talk about prevention. I'm sure you're familiar with the saying, an ounce of prevention is worth a pound of cure, and that is so true when it comes to diabetes. You, the patient, play a very significant role in treatment and prevention. Being on top of your doctor's visits and your diet and all those things. So let's kind of go through this slide and talk about the key to prevention. And these are things that you should bring up with your primary care if you have diabetes. Diet, of course, is the cornerstone of treatment. And what is that diet? What is recommended? Because there is so much misinformation out there about diet. You know, in evidence-based medical trials, Mediterranean-style eating is the time and time again is really what's good for overall health, not just diabetic, but also cardiovascular, anti-inflammatory, all those good things. So if you think about the countries around the Mediterranean Sea, Italy, Spain, those kinds of places, what do they eat? They eat a lot of fish, a lot of seafood. They eat a lot of olive oil. They eat nuts. They eat lots of fruits and vegetables. We in the United States recommend 5 servings, but some of these diets, they even want you up to have 10. So really you can't overdose on your fresh fruits and vegetables. And you're staying away from those processed foods, those processed sugars. A good guide when you're at the grocery store is to walk on those outside aisles and shop, not go on those inside aisles where all the processed and boxed food is. And when we talked at the beginning of the talk about your A1C, you want that to be below 6.5%. If you're a little bit more of a brittle diabetic, a good goal is 7. And then, of course, going back to the point about that active lifestyle, that activity is so important. Even in research studies, a 20-minute walk a day has shown a big impact on your health. So if you can move, do it. If you're sitting, start walking. If you're walking, walk faster. If you're walking fast, jog. So just try to push yourself. And, you know, my patients ask me, well, what kind of exercise should I be doing? I always suggest something you love, something that brings you joy, something that you're going to actually do. I'm happy with them doing. So if you like your swimming class with your friends, go do that. If you like to go play pickleball, I'm all for it. So, you know, it's not something that I want patients to not enjoy. It should be an enjoyable part of your day. I do want to mention, though, we're doing more and more research on weight and weightlifting and muscle mass. And we know people who keep up their muscle mass as they age do much better. There's a couple reasons for that. Metabolically, it really helps. It decreases blood sugars. It decreases that insulin resistance to have a higher muscle mass. It increases your metabolic rate. So when you're just sitting there, you're burning more calories. It also helps your bones and your joints as you start to develop arthritis. It helps to keep them strong, those tendons and ligaments strong, so the joint can still function. And then it helps prevent falls, which is a huge thing for patients over 65. So the more muscle you have, the more likely you are to protect yourself when you go into a fall. And it also, weightlifting helps with your coordination. So I want to put a plug in there for resistance training or weightlifting. It's never too late to start to do some of that. So let's talk a little bit back to your feet. So if you have diabetes, I recommend that when you get out of the shower or the bath every day, you just sit down and look at your feet. It's like brushing your teeth. You want to take a good look at your feet every day. Because when you have neuropathy and you can't feel things that are starting on your feet, sometimes you're not going to know. A good way to do that is to sit on the edge of the bed or even on the toilet, bring that foot up on your leg, look in between your toes. I know that's not always possible. Some patients have trouble bending over. You can have a loved one do it, or they sell nifty little mirrors that you can look at the bottom of your feet with. They're probably, I didn't look on Amazon, but I'm sure they're quite cheap. So those are all good options. Keep an eye on things. Get to your doctor if you see a problem. This is really important. Wear shoes that fit appropriately and cover your feet. I see a lot of injuries for my diabetic patients who are walking around barefoot. I really recommend against that. Hence my patient I have in wound care right now. He's had this ulcer for 2 years, and that was from a burn. And it's totally preventable. So wear shoes, don't go outside barefoot, and wear appropriate shoes that aren't rubbing. And if you need to, Medicare pays for diabetic shoes. I think your blood sugar has to be elevated. Don't quote me on that, but podiatrists can help you with that, okay? If you are starting to see lots of callus formation, that's just telling you that your skin is rubbing. Your body's reacting to some kind of friction, and you need to get in and see a podiatrist so they can take a look and see if you need an offloader. We have different kinds of felt pads we can put on shoes to keep the pressure off of that part of the foot, and then also to trim it back, because those calluses can quickly turn into a wound underneath. Patients will come see me, I kind of look, I peel that off, and there's a huge wound that's been hiding under there that they didn't know about. So has anyone had this microfilament test with their primary care? Okay, if you have diabetes. If you don't, we're not going to have it done. I'm glad to hear that, because that's a really important screening tool, and I don't want to talk bad about my colleagues, but if you have diabetes and your primary care is not looking at your feet and doing this at least once a year, that's not good. That's not good care. You should be asking for it or finding a new provider. That monofilament test, and I'm going to show you a picture, but it does little tiny pokes all over your feet to see if you have any decreased sensation. Once we know that you do, then you have neuropathy, and we want to be really hypervigilant of your feet, your foot care, all those good things. And then the annual foot check, because they should also be looking at your orthopedic. If you have deformities, they should be checking your pulses, that pedal and tibial pulse in your foot. We look at skin changes. We look and see if you've lost hair down there. Losing hair growth on your lower legs is a sign of poor circulation. So all these things are important for us as primary care people to take a look at, and then we can follow up accordingly. I know you've all had this message, but smoking and diabetes as far as foot wounds is just really bad. It's kind of like throwing gasoline on the fire. So please talk to your primary care. If you're having trouble quitting, we're happy to help with offering medications and or services to help you quit.
Are you talking all smoking, like tobacco, weed,
So
just tobacco?
yeah, good question. So marijuana does not have the same kind of arterial complications as far as causing that arterial inflammation. So it's not as much of an issue for wound care, but anytime you put something that's a combustible into your lungs, you can cause lung damage. So I don't recommend smoking anything, but as far as the marijuana, no, it doesn't cause the foot wounds. So let's talk about cholesterol. So when you're diabetic, you want to control all the other things that might cause a problem as far as your vascular space. LDL is the part of your cholesterol that's that bad cholesterol, okay? So that's the one we see that forms those plaques in your arteries, around your heart, that kind of thing. And so in the normal population that doesn't have diabetes, we like to do less than 100 as a goal. That's a good goal to have. But when you have diabetes, we want to get it even lower, because we don't want to add fuel to that fire and cause more problems. So you should be below 70. 70 is a pretty hard number to get. Most people can't do that on their own. So if you have diabetes, you really should be on a statin. If you're not, you need to talk to your primary care about it. Statins are those cholesterol drugs. Atorvastatin, Crestor, Lipitor, Simvastatin, correct. And the research on this time and time again is that those statins decrease these complications as far as the arteries in your legs and feet, but also your heart, strokes. They're life-saving, they're life-promoting, they're really important. So talk to your doctor, and if you can't tolerate them, there are some alternatives out there. But 90% of people can tolerate them without many complications. Blood pressure management. Again, if you've got high blood pressure and you've got diabetes, you're gonna throw fuel on the fire. So you wanna get that blood pressure down. A good goal is to have that top number between 100 and 130. We know that we had a big study, oh gosh, it was probably 10 years ago now, where they put a lot of people, like 25,000 people in one group and 25 in the other, where they controlled one group less than 130 and another group less than 150. They had to stop the study halfway through because the group that was 150 was having such worse health outcomes. The group that was 140 was cutting their risk for heart attack and stroke in half. It was that impressive. So this is a really important issue. I have patients all the time, oh, my blood pressure is 135, oh, it's 140. I'm like, yeah, that's not good. Let's get it down more, especially when you got diabetes. And then the medication class we like in diabetes are things called ACE inhibitors and angioretention blockers, because those help protect our kidneys.
What should the bottom number be?
Good question. Below 90?
Okay.
Yeah. So I tell my patients anything between about 60 and 55, 60 and 88. And if you're a diabetic, you should be on something for your diabetes, metformin, other medications, a statin, and one of those ACEs or ARBs.
So what's an ACE or ARB?
Those are a blood pressure class of medication. And even patients with diabetes that don't necessarily have high blood pressure, we sometimes put them on that. Not everybody can tolerate them because they have a protection in your kidney from the high sugars. So patients who are on, for example, lisinopril is an ACE inhibitor. It's a blood pressure med. Patients who take that long term have less kidney damage that have diabetes. I should preface my talk, it's individualized to you. You talk to your provider because these are rules for everybody, but sometimes they don't follow you and your specific needs. But these are a good rule of thumb.
So is lisinopril, because I used to be taking 10 on that, now I take 5.
Mhm.
Because I didn't need that much. So is that, if you're on it, does it fluctuate the amount? Can you repeat that question?
Oh, yeah, sure. So we have a guest in our audience talking about lisinopril and if the dosage changes. She was on 5 and now on 10. Probably did that to titrate your blood pressure lower. The 5 milligram is fine for the kidney protection. So that's that monofilament test that I was just talking about on the left-hand side. So if your doctor pulls out that little thing, I promise it's not a needle. It's not going to hurt. It's just to see if you have good sensation down there. And then on the right, getting a hand mirror, a special mirror, so you're having an easier time to see the bottom of your feet. And then on the left there, that's a diabetic shoe. And you can see that little piece sticking out, that's an offloader. And those can be personalized to your foot and your specific anatomy and what's going on with your podiatrist. And many times Medicare covers that. And I just want to preface that you have a lot of power in preventing these complications. Most, if not all, these diabetic complications in patients are preventable. That's why it's so frustrating for me to see patients coming in time and time again in the wound care center with bad outcomes, because I know that they could have gone down a different path if things have been different. And there are a lot of reasons for that. That's not always the patient's fault, but.
They're all so ugly, though.
The shoes.
I just don't know why they couldn't put something.
I think there are, I picked an ugly shoe, I want to agree with you, but I think there are some nicer, some better looking shoes now. They don't all look like that.
Okay.
I'm going to skip over this because I want to make sure we have enough question time. So these are our key takeaways today. Diabetes is common, yet it's preventable and treatable, definitely. And then you're in the early stages or the pre-diabetic stage, it can even be reversible. So we really want to catch patients in that stage and get that blood sugar under control before they're too far gone. Diabetic foot wounds are prevented with good glucose control and proper foot care, as well as recognizing them early and getting into your proper treatment as soon as you can. We have multifactorial reasons for diabetic foot ulcers. We have problems with our nervous system, orthopedic, vascular, and infection reasons. And diabetic foot ulcers can be complex and need to be treated by multiple specialties of nurses and doctors. So this is just another plug to keep very good surveillance on your feet. And if you've got ulcers, get that medical care that you need, any kind of wounds, okay? The earlier you get in to see me at the wound care center, the better. And that's my last slide. And these are my 2 offices. I think Maya's gonna help when we're all done about if you need a wound care referral or information, but that's our, the 2 offices that I work at and our contact information. So we're gonna open the floor now to, I think, our streaming audience. Is that correct, Maya?
Yes, yeah. Thank you, Natalie. That was really informative. And I do have some questions that have come in that I'd like you to see what you can answer here. One was about a doctor's referral. So you do need a physician referral for the TMC Wound Care, correct? You cannot self-refer. Somebody asked.
Yes, exactly. So, especially if you have Medicare, Medicare requires you have a referral. Most of the time we get those from primary care offices, but you could also be, say your vascular surgeon wants you to come see us, or you were in the ER and you need to get in. So sometimes
oncologist, right? Or your oncologist. I know.
Yes, we get plenty of referrals from oncology. Yep, exactly.
Okay. I've also put the phone number up for the TMC Wound Care. It's 520-324-2440. So if you have questions, please feel free to reach out to them as well, but you will need a referral to get started. Now, for a diabetic foot ulcer, how long is the treatment time? I know it's individual, but is there an average amount of time that somebody would be coming to the wound care for help?
Yeah, that's a great question. So those plantar ulcers where you saw on the bottom of the feet, those tend to be the trickiest and longest to heal. I've had patients where it can take at least 6 to 8 weeks, but I had patients that took me over a year to get closed.
And so how often do they come, Natalie? How often would they come into the wound care?
Good question. So they come in once a week for a treatment visit, and that's where we do that debridement. We numb you up with lidocaine. We do the surgical. We take an assessment of the wound, look for any potential problems. We put on a new dressing, and then we have our patients do 1 dressing change in between visits at home. Either they do it themselves or we arrange for home health nurses to come in.
Great. Now let's talk a little bit more about the shoes. The lovely shoes, right? Are there types of shoes that would be better for preventing foot complications? Maybe you don't have a wound now.
Sure.
Diabetic. Is there something that people should be looking at when they're choosing their footwear?
Yeah, I think the biggest thing is that the toe box fits you correctly. So you don't want a toe box, which is the end of the shoe there, being too tight and rubbing. So it's better to get something wide. Of course, things that cover your entire foot, like just a regular old tennis shoe that's comfortable for you to walk in. I can't really recommend a brand over the other because certain brands are better for certain types of people, but those are good things to make sure the toe box is wide enough, it's not slipping in the heel, and that you're actually wearing it and not walking around barefoot.
Okay. Are slippers, if somebody is at home and they aren't wearing necessarily a shoe, can they wear a slipper? Would that be okay or not? Or is that not recommended?
I mean, you can wear a slipper at home. They're a little bit of a trip hazard, so just know yourself and be careful. The flip-flops I'm not a huge fan of because your whole foot isn't covered. So yeah.
Right. Okay. And there are some slippers where it's more like a shoe too, yeah. So that you wouldn't have the back, you wouldn't be flapping in the back, I guess.
Exactly.
Now, if somebody notices that they have a wound on their foot, what steps should they take to help prevent it from worsening?
So if you are diabetic and you have a wound, you need to get medical care right away. So first stop is your primary care office if you have one. I know not everybody does. If that's not possible, then if it looks red or hot or swollen and there's drainage, you have any kind of infection, unfortunately, I would recommend you go to the ER because if you're a diabetic and you have a foot infection, you do not want to mess around with that. If it's not infected and you're just wanting a referral or some more information, you could try to get in to see a podiatrist if you have one, or you could go to an urgent care.
Okay.
But the office is the first starting point.
And then I was going to mention on the podiatrist. So if you are diabetic, how often should they be seeing a podiatrist in addition to their in addition to their primary care? How often would they be doing that a year?
Well, it's a little bit varies by patient. So if your feet are in good condition, seeing your primary care once a year and getting that monofilament and pulse check is adequate. But if you've got, deformities, bunions, that kind of thing, or you have a lot of calluses, then you should be seeing a podiatrist at least once a year, if not more often.
Okay. Now, is it inevitable that if you have diabetes that you're going to experience a diabetic foot concern, or is this something that can be prevented?
It is definitely not inevitable. Diabetic foot ulcers are sort of a red flag to me that this patient hasn't had good care of their diabetes for many years. They don't just start overnight. That diabetes has kind of been going on for a while. So taking care of the blood sugars, doing all the things you're supposed to do, and you will not end up with one.
Okay, well and I don't think you don't want one, so if we can avoid it, that's always great. And my last question is about the environment. So is that something that impacts our foot health, such as the dry desert weather here, or maybe living in a humid environment?
Yeah, definitely. So if you're in a humid environment, you're going to get more of that moisture in your foot, more fungal infections, what we call maceration. When the tissue gets kind of white and moist, it breaks down. And then if you're in that dry environment, you get cracking, fissures. So we call wound care the Goldilocks, right? We don't want too much moisture. We want a little bit. We don't want too much dryness. We want a little bit. So just being aware of your foot type and what issues you have. I'm a big fan of just regular old Vaseline on your heels at night if you get a lot of cracks and dryness as prevention. And then if you're moist, doing some kind of powder like a cornstarch powder or antifungal powder over the counter in your sock in the morning.
Are pedicures also good?
Pedicures are definitely good as long as they're not too aggressive and aren't cutting your skin. So just talk with your pedicure person and say, I have diabetes. Please be aware I don't want any cuts. But it is good because they can get a lot of that dead kind of tissue off of your heel and your calluses and keep your nails looking nice.
Right. Okay. So I've put up the phone number one last time. It's 520-324-2440. So please, if you've got any concerns and are in need of wound care, also, will you just share where the wound care, where TMC Wound Care is located?
Yeah, because it's not on the it's not on the main campus. We're over on the El Dorado campus. So it is on Wilmot, in between Pima and Speedway. There's a Cornerstone Behavioral Health Hospital. We're attached in that same building. The TMC Infusion Center. We're all in that building there.
Yes, and actually, where TMC for Seniors used to live, so we're in the whole building as well. But I know it's been a few years, so I'm not sure if people are aware or not. I want to thank you so much for being here today, sharing what is incredibly important for folks who have diabetes. And if you don't, but you might have another wound, this is really helpful as well. I'm going to close up with our online audience, and I'll turn it over to you to answer any questions in person. So thanks for being here, Natalie.
Yeah, and thank you to everyone for joining me today.
Thanks. Thanks again. We will be back. We'll be back for one more diabetes program this month, and that is going to be navigating the intersection of diabetes and oral health. That will be next Tuesday, November 19th at 10 a.m. So if you'd like to join us for that class, we do have room in person or online. The phone number is 520-324-1960. I also wanted to share another important topic that we'll be holding later on today. We'll be doing biliary breakdown, understanding gallbladder disorders with Dr. David Liu. He is a TMC 1 general surgeon, and that'll be Tuesday, November 12th at 3 p.m. So if you would like to join us for that class, the phone number again is 520-324-1960. We'd be happy to get you signed up, or if you'd like to attend in person, we've got room for that as well. We look forward to seeing you soon. Thanks for being here.